Hey, welcome back to Not So Complicated, and it's day 12, clinical case discussion 12, as we have been doing since 12 days, and we are also studying Study With Me series. The first study is USMLE step 1 line by line. So if you haven't joined, you can join with us. We are building a community to crack USMLE with under 60 plus. So let's begin today's case. It is that a 4-month-old male infant is brought to the pediatrician due to poor feeding, excessive sweating, and rapid breathing for 3 weeks. The mother reports frequent respiratory infections since birth. He was born at term with no prenatal complications. Physical examination shows a weight of the 5th percentile and respiratory rate of 50 per minute, heart rate of 140 per minute, and oxygen saturation of 96% on room air. There is a harsh holosystolic murmur at the left sternal border, a hyperdynamic precordium, and hepatomegaly 2 cm below the costal margin. And then lungs reveal bilateral crackles. Echocardiography shows a 7 mm perimembranous ventricular septal defect. Okay, so it is a case of VSD, right? And that hepatomegaly and also bilateral crackles may be due to overcirculation of pulmonary region, and also left ventricular dilation, and a pulmonary to systemic flow ratio is of 2.5, and laboratory results are unremarkable except for elevated B-type natriuretic peptide BNP at 600 picogram per milliliter. Normal is less than 100 picogram per milliliter. So our major findings are highlighted in red. So which of the following best explains the infant's clinical presentation? Left to right shunting. Because there is ventricular septal defect, there must be left to right shunting if it's in the initial phase and if it hasn't developed Eisenmenger syndrome, right? So causing pulmonary overcirculation. This might be the case. Let's see other options, which are right to left shunting causing cyanosis. There is no sign of cyanosis in this case, so this might not be the case. Even if this is not the case, we will deep dive into every options, and also we will deep dive into the management of the correct diagnosis, right? And also aortic regurgitation secondary to VSD prolapse, it can occur, but there are no signs of aortic regurgitations in echocardiography either. So left ventricular outflow obstruction, pulmonary valve stenosis. Let's begin each by each. So first option we had is left to right shunting causing pulmonary overcirculation, right? The infant's poor feeding, sweating, tachypnea, failure to thrive, recurrent infections suggest congestive heart failure. So the most common cause of congenital heart disease that causes congestive heart failure is ventricular septal defect. Okay, we are seeing the signs of ventricular septal defect right here. And also holosystolic murmur, hepatomegaly, crackles, 7 mm perimembranous ventricular septal defect, QP by QES 2.5, LV dilation confirms significant left to right shunting. How they confirm this? Because there is holosystolic murmur. Holosystolic murmur means that the murmur starts from the first heart sound and ends at the second heart sound, and the murmur is entirely in all that systolic phase. It actually occurs because the left ventricular pressure is usually 100 mmHg and then the right ventricular pressure is 25 mmHg. So there is a gradient between these two ventricles, right? So basically, if there is a hole that is also perimembranous VSD is the most commonest type of VSD with 90% of cases. So that hole, even if the pressure of left ventricle comes down during systolic phase, it will still be above the pressure of right ventricle, and that is why there is holosystolic murmur. And holosystolic murmur is heard in left lower sternal border, as we talked about it, because the perimembranous portion of interventricular septum usually underlies in that region. So that is why it is the case. So in 10% of the cases, there might not be the holosystolic murmur heard in LLSB, that is left lower sternal border. So crackles due to pulmonary congestion is there. How do we look at pulmonary congestion in X-ray? X-ray, we see bronchoscopy markings with left anterior descending artery dilated. That is how we see in crackles in X-ray, right? And there is 7 mm perimembranous VSD, as you can see in there. Echocardiography, as I have already attached the picture, and QP by QS is 2.5. And also we will talk about this restrictive, non-restrictive, and also moderately restrictive, this classification, this hemodynamics of this case. confirm significant left to right shunting, right? And elevated BNP, because there is cardiac stress. Since there is volume overload in left ventricle, there is cardiac stress, and that stress is elevating brain natriuretic peptide almost 600 picogram per milliliter. And in a large VSD, high LV pressure 100 mmHg drives blood to the RV, that is 25 mmHg, increasing pulmonary flow, causing pulmonary edema, that is crackles, and also left ventricle by right ventricle overload, hepatomegaly, and LV dilation is due to that reason. And there is no cyanosis because there is oxygen saturation of 96%, which rules out right to left shunting. So basically it is very highly likely that this is our diagnosis, but still let's tap into the second option. Second option is right to left shunting causing cyanosis. Right to left shunting, which is USMLE syndrome, it usually requires pulmonary hypertension to elevate RV, that is right ventricular pressure, above left ventricular pressure, right? And this infant has SpO2 of 96%, so which means there is no cyanosis, and echo confirmed that there is left to right shunting, that is QP by QS equals 2.5. And also CHF symptoms like crackles, hepatomegaly reflect pulmonary overcirculation, not hypoxemia. And in USMLE syndrome, it occurs later in adolescence or adulthood, but our patient is 4 months infant, 4 months old, right? So USMLE syndrome actually occurs like there is systemic to pulmonary circulation connection. There is left to right shunting of the blood at first, right? So all the blood from left ventricle will go to the right ventricles, right? And that right ventricle has the volume overload, which he has it has to pump the blood against the it has to pump the blood to the lungs, right? And since there is pulmonary arteries, there are dilatation of pulmonary arteries because of the volume overload at the first state. But in the as time passes by, these arteries get fibrosed, and that is why there is pulmonary hypertension. There is resistance, right? So the right ventricle has to pump harder to override that resistance. So to pump the harder, there is increased workload in the right ventricle. That increased in workload will cause right ventricular hypertrophy and also volume overload. Thus volume overload will now there occur reversal of shunting to the right to left side, and that is how it occurs, right? Yeah, there is a pathophysiology attached in it. And also the third option we have is aortic regurgitation secondary to VSD prolapse. In perimembranous VSDs may cause aortic cusp prolapse, leading to aortic regurgitation with a diastolic murmur, right? It can occur, but this infant's holosystolic murmur, congestive heart failure, and echo, where there is no aortic regurgitation noted, points to left to right shunting. And also aortic regurgitation is a later complication, not the primary cause at 4 months, so it is very unlikely. And the signs of aortic regurgitation I have attached in here. There are a lot of signs, and we will discuss each of them in our aortic regurgitation cases and also in our study with me series. But right now you can only look at the names like lighthouse sign and Lanloff sign, or Baker's sign in eyes, Muller's sign in mouth, and Corrigan's neck sign, Corrigan's pulse, Rosenbach's sign, and Gerhardt's sign, Quincke's sign, and Doris's sign, pistol shot femorals, Trapp's sign, water hammer pulse. This is very important sign of aortic regurgitation, which is water hammer pulse. So we now go to the fourth option that we have, which is left ventricular outflow obstruction. Left ventricular outflow obstruction, that is usually due to aortic stenosis. It usually presents with systolic ejection murmurs and also pressure overload, not CHF. And this infant's holosystolic murmur, LV dilation. LV dilation, left ventricular dilation, in this case is actually eccentric dilation. That is, the fibers are added in series, not in parallel as in hypertension, right? So hypertension, there is concentric dilatation, but in this case there is eccentric dilatation of left ventricle, and QP by QS ratio is 2.5, which indicates VSD shunting, which also does not indicate that there is obstruction. The echo shows no aortic narrowing, so this is very highly unlikely. Also, I have attached a picture in here, like mitral valve leaflets. There can be increased mitral leaflet length and area, and also AML percussion injury. And in mitral annulus, there can be mitral annular calcification, reduced systolic annular excursion, and cardiac tendini. There can occur caudal rupture, access caudal laxity. Obviously, these are all the reasons for left ventricular outflow obstruction. In PMs, there is that is PM means papillary muscle. Papillary muscle hypertrophy can occur. Anterior papillary muscle fusion, medial papillary muscle displacement, accessory PMs, apical PM displacement, doubly bifurcated PMs, and PM fibrosis, which is also remodeling, can occur. So these are the causes for left ventricular outflow obstruction. The fifth option we have in here is pulmonary valve stenosis. So pulmonary valve stenosis causes systolic ejection murmur at the upper left sternal border, right? So you have to understand the reason why it is hard in upper left sternal border. For that, you have to study the anatomy. This is a homework for you. And in right ventricular hypertrophy cyanosis, if severe, like in tetralogy of Fallot, this infant's holosystolic murmur, bilateral crackles, LV dilation point to VSD with left to right shunting, not pulmonary valve stenosis. Echocardiography also shows VSD and QP by QS 2.5 with no mention of pulmonary stenosis or right ventricular outflow obstruction. Since pulmonary valve is present in the pulmonary tract or the outflow tract of right ventricle towards the lungs, so there is no any signs of right ventricular outflow obstruction. There are CHF symptoms, which is due to pulmonary overcirculation, not right ventricular pressure overload from pulmonary stenosis. So this is very highly unlikely. That is how pulmonary valve stenosis occurs, as I have shown in the figure, right? The valve falls to open fully, making blood flow difficult, and that will in long term cause right ventricular hypertrophy. You have to remember that. Right ventricular hypertrophy is also called cor pulmonale, and that is presented as parasternal heave. So the diagnosis we have is left to right shunting causing pulmonary overcirculation. So the mechanism actually is left to right shunt and increased pulmonary blood flow, shear stress or circumferential stress is done. As I have said already earlier, the added fibers are in series, and also endothelial dysfunction and vascular remodeling occurs. Smooth muscle cell proliferation, increase in extracellular matrix, and intravascular thrombosis can occur. So that will increase in pulmonary vessel resistance, and that will cause the reversal of shunt, that is right to left, and this is called Eisenmenger syndrome. That is how the fate of left to right shunting is. And also the hemodynamic classification of left to right shunting or ventricular septal defect is that there are restrictive, moderately restrictive, and non-restrictive. Restrictive VSD are usually resistance that limits the shunt at the site of VSD, right? So LVSB is greater than RVSP, that is the left ventricular systolic pressure is greater than right ventricular systolic pressure, as I have talked earlier, 100 mmHg and 25 mmHg. And pulmonary or aortic systolic pressure ratio is less than 0.3 in restrictive case. QP by QS is less than 1.4 by 1. And in moderately restrictive, RVSP is slightly high but still less than LVSP, and QP by QS is 1.4 by 2.2 or 2.2, like that is the range. And in non-restrictive cases, the shunt is not limited at the site of defect. RVSP, LVSP, PA, aortic systolic pressures all are equal, and QP by QS is greater than 2.2. So flow is determined by pulmonary vascular resistance. That is how it occurs. The diagnosis, the clinical features, there are large ventricular septal defects as congenital heart disease. The symptoms are poor weight gain or weight loss, as we have seen in this case. And that is that the patient lies in the 5th percentile, and also difficulty in feeding, sweating on forehead, frequent cough and cold, pneumonia, hospital admissions, shock, rest, shock cycles. The small BSD are often asymptomatic, but moderate BSD are above symptoms but in less intensity. So the classification of BSD and according to the anatomical location can occur. So the type 1 is 5 to 7% of isolated BSD, that is conal or subpulmonary or infundibular or supracrystal BSD. Type 2 is 70% of VSDs, that is perimembranous, that is paramembranous or conoventricular VSD. As you can see in the figure, the location is right there. And in type 3, that is 5% of VSDs typically occurs in Down syndrome, peri-inlet, AV canal, AV septal, endocardial cushion. And in type 4, 20% of VSD is muscular defect. So the management of large VSD with left to right shunting, the immediate medical management should be diuretics, that is to reduce the congestion and volume overload, that is used furosemide to reduce pulmonary edema and preload, alleviating crackles and hepatomegaly, monitor electrolytes. Hypokalemia is risky in diuretics, because so potassium sparing diuretics can also be used if the hypokalemia develops. ACE inhibitors, captopril 0.1 to 0.5 mg per kg per dose, Q8 hour to lower afterload, improving LV function and reducing shunt volume. And inotropic support is also given. Digoxin will cause inotropy, that is the myocardial contractility will increase with this. For infants with severe CHF to enhance contractility, though used cautiously because of narrow therapeutic window. And nutrition, high calorie formula to support growth, addressing failure to thrive. Nasogastric feeds if feeding is poor. And in oxygen, we have to give up supplemental oxygen if SpO2 drops less than 92% to reduce pulmonary vasoconstriction, though not needed here. That is SpO2 96% is already maintained. So the management in surgical or interventional management, the indication, if not all cases should be managed by surgical or intervention. So basically the indication for the large VSD with QP by QS ratio greater than 2.0, CHF and failure to thrive as seen in here, you can do the patch repair. Patch closure or Dacron or pericardial is used using by a median sternostomy, and 95% success rate is there, less than 5% mortality in infants. Transcatheter closure, less common for perimembranous VSDs due to aortic or tricuspid valve proximity. As you can see here, the patch closure is here. So the timing of surgical repair at 3 to 6 months to prevent pulmonary hypertension progression, and earlier 1 to 2 months if CHF is refractory. The complications of surgical interventions include residual shunts 5 to 10%, complete heart block in 1 to 2%, and right ventricular dysfunction can occur. So the management in supportive care, we have to do infection prophylaxis by administering antibiotics, example amoxicillin 2 gram before dental procedures. Why dental procedures? Because it has a high risk of developing into complicating into infective endocarditis as per American Heart Association, and to prevent endocarditis of 5 to 10% lifetime risk in BST. Monitoring, we have to do weekly clinical assessments, weight, respiratory rate, repeat echocardiography at 1 to 2 months to monitor left ventricular dilation and also pulmonary hypertension. So thank you, that is all for today. Subscribe for our next clinical discussions and staying with us. We will be cracking our USMLE step 1 just like this. Thank you.